continuation on today's session is a continuation on the gynecological cancer series, basically the cancers that affect the reproductive system of women. And today's topic is a discussion on cancer of the uterus. Our discussion today will be Dr. Innocent Maranga. He's a gynecology oncologist at Kenyatta National Hospital, and also is available at the Gynaecological Cancer Hospital, which is located also in Nairobi. Uterine cancer is one of the leading cancers, especially in Western Europe and the Americas. Maybe in our setup, it could be like number 4 among the reproductive health cancers. And if you manage well, the outcome is caught early and managed well, the outcomes are good. So I invite Dr. Maranga to take us through, then we will have a discussion once he's done with the main discussion. Dr. Maranga, you're most welcome. Karibu sana, and take us through. Dr. Maranga? Dr. Maranga, we can't hear you.
Yeah, I guess now you can hear me.
Hello?
Can you hear me now? Can you hear me?
Yes, Dr. Maranga, we can get you loud and clear.
Okay, thank you. Okay, I guess now you can hear me. Are you able to see the screen?
I can see it from my end.
Okay, thank you. So I'm going to start it off. Thank
Can
you,
you
Dr. Thank you, Dr. Mukomba. Thank you, the hosts for this webinar. So we're going to discuss about cancer of the uterus. And as Dr. Mukomba mentioned, this is one of the common cancers that we treat. They never used to be as common, but now they are common around, probably due to lifestyle change and other factors which we're going to look at. Among the cancer of the uterus, we have those which start from the endometrium. Those are called endometrial cancers. Those are the most common. But we also do have others which start from the corpus. It's like the myometrium and the other stromal tissue. Those are the ones which form the sarcomas. Our concentration this afternoon will be on endometrial cancers. Thank you. Come again? Yeah, so
okay,
it has moved now. As you can see on that blue bit, that is the endometrium. Endometrium is basically the inner lining of the uterus, and it's the commonest area to have a cancer start within the uterus, of course, apart from the cervix. That's just to show some of the surgeries which are done, not necessarily for the endometrial cancer, but basically gynecological oncology types of surgery. Now, of note is cancer of the uterus is, if diagnosed early, and most of them are actually diagnosed early, so long as the patient presents early to us, it actually does present with postmenopausal bleeding most often. And at that particular point, there may be a bit of delay because the patient may dismiss or may be ashamed as they're older women while they're starting to resume their menses. But if they do present themselves to you, then we should be able to suspect a possibility of endometrial cancer. So most of them do present relatively early, so long as they are diagnosed, so long as the patient comes early to us. It's also one of those cancers which we, as healthcare workers, and especially as doctors, we may tend to underrate and sometimes not to treat them appropriately. It is one of those mismanaged, most mismanaged female genital cancer, whereby the actual thinking out here would be everybody thinks that it is just a simple hysterectomy or just doing total abdominal hysterectomy. Can you hear me, Dr. Makomba? Am I audible enough?
It's breaking.
Oh, it's breaking.
Yeah, but it's breaking at some point.
Okay, I'll try.
Continue now, it's clear.
Okay, so we are saying that the previous dogma, which was that endometrial cancer is just a simple hysterectomy, has since changed, and there's been a lot of changes which have occurred in the management and approach of endometrial cancer. As you're going to see most often, especially for stage 2, which we're going to have a look at, we would tend to treat it as cervical cancer by doing radical hysterectomy, pelvic lymph node dissection, paraortic lymph node dissection, and also a mentectomy apart from peritoneal washout, which, depending on the stage and presentation, the patient may also require external beam radiation or internal radiation, which we call brachytherapy. And also, depending on the stage and presentation, chemotherapy has a place. We're going to have a look at all this. Having said that, the gynecologist will tell you that this is one of the most lethal. It's actually one of the most lethal when it comes to the female genital cancers, especially when recurrence occurs. And when recurrence occurs, almost always it's fatal. This is one of those cancers that the best chance is to have initial appropriate and aggressive management, because you have that single magic bullet at that particular time. When it recurs, then you find it is often unforgiving. There are several types of endometrial cancers, as we're going to see. They are not just one entity. Sorry. So that is basically to show the anatomy. I'm trying to get my cursor, but it keeps on moving. So that is why I've gone a bit slow on that. So as you can see over there, that's the endometrium. And you could have a cancer developing over there. And then what you are seeing is the lymphatic system. So some of it may go to the inguinals, the obturator nodes, the external iliac nodes, the common iliac nodes, the aortic nodes. So lymphatic system is extremely important, just like in the cervix. And that's why the management has changed towards more of doing lymph node dissection than previously. Previously, it used to be mainly THBS, or total abdominal hysterectomy, bilateral salpingo-oophorectomy, but that has changed, as we're going to see shortly. Now, if you look at the epidemiology, sorry, a bit annoying there. Endometrial cancer is the most common malignancy of the female genital tract in the Western world. And it's been attributed to probably a high body mass index and obesity. In Kenya, of course, we know the most common is cervical cancer still. However, still in our setup, Black women have a 40% lower risk of developing the disease, but a 54% greater risk of dying from endometrial cancer. And this is mainly due to late diagnosis in our setup for the reasons which we just alluded to. There are two different clinical pathological subtypes of endometrial cancer. I believe among us, we do have those who work in the lab and pathologists. We have the estrogen-related type 1, which is we commonly call endometrioid. And then we have the non-estrogen related, which is type 2 or non-endometrioid. Pathologists would usually tell you these are classified as either clear cell or serous endometrial cancers. Now, approximately 80% of newly diagnosed endometrial cancers in the Western world are endometrioid in type. And we did also an audit and a review last year at KNH, looking at the previous around 10 years. And it wasn't any different from this. We find that almost a similar number are these endometrioid types. Now, this is from Nairobi Cancer Registry. You see there, breast is number 1. Cervix there is number 2. You have esophageal, large bowel, stomach, ovarian cancers, liver, non-Hodgkin's, Kaposi's, and the brain and nervous system. So in terms of the top 10, it's not among them, but as you can see, if you look at the female genital system, then it would actually come after the cervix, after the ovary, and then next it will be somewhere there. Now, let's look at the risk factors. This is important when you're trying to make a diagnosis of this type of cancer. As part of the history, most often this patient is nulliparous. They tend to have early menarche and late menopause, often more than 55 years. And there's a triad which we call, we basically refer to it as a triad of hypertension, diabetes, and also obesity. Those tend to be quite common. And then scenarios of unopposed estrogen, where we have either estrogen therapy or chronic anovulation, like in polycystic ovarian syndrome, estrogen producing tumors, the use of tamoxifen, especially those who use it for breast cancer. Tamoxifen is often used for breast cancer. So one of the risks would be development of endometrial cancer. And for those patients whom we find have atypical endometrial hyperplasia or have hereditary non-polyposis colorectal cancer, that is usually a family history of the same. For hypertension, as you have said, advanced age, this often occurs more during the postmenopausal period. Previous pelvic radiation, inactivity, infertility, those are some of the risk factors. We, however, have protective aspects, like those who use oral contraceptives, they may tend to be more protected. Those who use postmenopausal progesterone. Ironically, smokers also do come in. Exercises, they tend to have a reduction of around 30%. We also do have hereditary syndromes which are associated with endometrial cancer. As I've said, that is hereditary non-polyposis colorectal cancer, or what we generally call as Lynch 2 syndrome. Now, the lifetime risk of endometrial cancer in such people is between 20 and 50%. That's pretty high. Now, the average age of with endometrioid cancer is approximately 63 years, and 70% or so are confined to the uterine corpus at the time of diagnosis. The 5-year survival is approximately 83%. So as you can see, it has a better prognosis. That one we call endometrioid. By contrast, the average age of patients with non-endometrioid cancer is 67 years. These tend to be a bit older, and at least half have already spread beyond the uterus at the time of diagnosis. Their 5-year survival rate is therefore lower at 62%. And these are mainly clear cell carcinomas at 62% and 53% for papillary serous cancer. So in other words, what you are trying to say, it's not enough to say somebody has endometrial cancer. We would generally want to find out what type of endometrial cancer it is, because the specific one will actually help us to prognosticate, to know what the likely survival. And of course, the stage is also important. Now, how do these patients present? Majority of them present with postmenopausal pervaginal bleeding, and that is the single most commonest symptom. You find a lady, an old lady, she has stopped seeing her periods, and then suddenly she starts seeing her periods. So during the history taking, we have to be clear in terms of the timing, the amount of bleeding, the pads, whether this patient has gone in for emergency treatment because of hemorrhage, the time since menopause, is it 1 year, is it a few months, are they decades after menopause? Does the patient have vaginal discharge? Could it be foul smelling? Has this patient been on hormonal replacement therapy, that's HRT? Does this patient have weight loss or back pain or pelvic pressure, bloating, bowel, or bladder complaints? Does she have leg swelling, for example, which may mean maybe there is pressure on the lymphatics in the pelvis? We have to look at what the age of menarche for this patient, the age of menopause. Were the cycles regular, or were they probably irregular with probable anovulatory cycles? The use of oral contraceptive pills, history of pap smear. So you're going to see pap smears tend to pick out 50% of the time endometrial cancers. Is there a history of sexually transmitted infections or any gynecological surgeries in the past? And in the past medical history, we need to find out, has the patient had mammography or a colonoscopy, because there's a relationship between breast cancer, colorectal cancer, and also endometrial cancer. History of hypertension, diabetes, and obesity, just like we have said, that particular of those three. And if there has been any past surgery done. I'm trying to move this and like it's not moving until there. Yeah, so the other bit is medication. Has the patient been on hormones, on aspirin, on anticoagulants? As the patient socially, the patient a smoker, alcoholic, drugs, and any past history of breast cancer, ovarian cancer, uterine cancer, colon cancer, prostate cancer, and possibility of BRCA1, BRCA2. Those are genetic aberrations or HNPCC inheritance, just like we have seen over there. Now, it's important to note that not every patient who comes with postmenopausal bleeding has cancer. Of note is, of those who come with postmenopausal bleeding, the majority actually will be having endometrial atrophy, a 60 to 80%. Others, not necessarily in our setup, but in the West, 15 to 25 might be on estrogen replacement therapy. Others may have endometrial polyp or endometrial hyperplasia, which is relatively also common in our setup. But because of that 10% in terms of oncology and in cancer presentation is pretty high, that of those who present with postmenopausal bleeding, 1 out of 10 will actually have cancer. That is very significant. And that is why we cannot afford to take it lightly when a patient comes to you with postmenopausal bleeding. And 5% of women with endometrial cancer are usually asymptomatic. And the lifetime risk of developing endometrial cancer is around 2.6%. Now, what do you look for in a patient who comes with postmenopausal bleeding and possibly cancer of the uterus? Look at the height, the weight, look at the BMI. Is this patient obese? On vital signs, hypertension. On physical examination, the patient may have supraclavicular nodes. And because of postmenopausal bleeding, the patient may have anemia. When you're checking the chest, there might be signs of pleural effusion, or basically signs of lung metastasis. It's important at this particular point to stress that the breast has to be examined for any lumps, and also at the same time check for axillary lymphadenopathy. In the abdomen, we check for masses, presence of ascites, liver enlargement, and then we do a digital rectal examination. That should not be forgotten. And in the pelvis, we do valvo, we check for lesions, evidence of vaginal atrophy or lesions. We check for cervical lesions, uterine size, adnexal masses. We check for nodularity in the cul-de-sac, that's the pouch of Douglas, the parametrium. We do a pap smear, and also we do endometrial biopsy. And we may take high vaginal swabs depending if there are signs of any infection. And also, of course, we check for inguinal nodes and also leg swelling. Now, previously we have had a discussion in this fora about cervical cancer, and screening is usually an important aspect of cervical cancer. And one therefore would ask, what about endometrial cancer? Can we screen for asymptomatic women? Now, the ideal method for outpatient sampling of endometrium has not yet been devised, and there's no blood test of sufficient sensitivity and specificity which has been developed so far. So we don't have a pap smear of sorts for this kind of cancer. So mass screening, therefore, in the population is not practical. However, screening for endometrial cancer or its precursors is justified for certain high-risk people. And it's difficult to have a recommendation, therefore, on screening. Now, who are these patients for whom screening for endometrial cancer is justified? One, this is postmenopausal women who are on exogenous estrogens without progestins. Those might be on treatment for postmenopausal symptoms, or women from families with hereditary non-polyposis colorectal cancer syndrome, or premenopausal women with an ovulatory cycles, such as those with polycystic ovarian disease or syndrome. Now, on the screening methods, only approximately 50% of women with endometrial cancer have malignant cells on the pap smear. The office endometrial sampling we use here mostly is Pipel, with the detection rates of endometrial cancer around 98%. Or we can do a TVS, or transvaginal ultrasound scan, where we look at the mean thickness of the endometrial strip, and usually above 4 millimeters, for a woman who is postmenopausal would usually be significant. 4% of endometrial cancers would be missed using transvaginal ultrasound for investigation of postmenopausal bleeding. So it's not like a woman is bleeding, you do a TVS, it does not show an enlarged or hypertrophied endometrium, and then we say we can actually miss it out. Now, we've already talked about tamoxifen, which is usually used for breast cancer. It usually increases the risk of endometrial cancer 2 to 3 times and produces sonographically unique picture of irregularly echogenic endometrium that is attributed to cystic glandular dilatation, stromoedema, and hyperplasia of the adjacent myometrium. So therefore, patients who are on tamoxifen are usually recommended to have regular checkup to rule out possibility of early endometrial cancer. Now, these are usually the devices that we use. The lower one there, that's what we call the Pipel. The upper one is called the Kevorkian. Those are used for endometrial sampling. Briefly, I'll just touch on the histological types. Really, the growth patterns of endometrial cancer, it may present as a focal disc lesion or endometrial polyp, or diffuse with several different areas or involving the entire endometrium. Like in that particular case, if you can see my cursor, that is really the tumor which is arising from the endometrium. What you're seeing over here, that is the myometrium. And on this particular side, you can see the invasion into the underlying myometrium. And this particular one here, it's more like almost all over the place where the tumor has eaten to the underlying myometrium. Briefly about the pre-malignant endometrial hyperplasia, because this is important, especially for the endometrioid type. And patients may come to us with postmenopausal bleeding, which may be due to endometrial hyperplasia, which may not as yet be endometrial cancer. So just like we saw in the previous talks on cervical cancer, where you have cervical intraepithelial neoplasia 1, 2, 3 as pre-malignant disease, this one also does have the pre-malignant entities. Now, endometrial hyperplasia is divided based on 1, architectural features, which are usually described as simple or complex, and 2, cytologic features, which could be classified into either typical or atypical. Now, this one usually results into 4 categories. We have simple hyperplasia, complex hyperplasia, simple atypical hyperplasia, complex atypical hyperplasia. So in other words, these are different entities of pre-malignant endometrial disease. Now, for complex of all these four, the complex atypical hyperplasia is most likely, any of them can progress to cancer, but complex atypical hyperplasia has a very high chance of progressing on to adenocarcinoma. So the percentages are there. So simple hyperplasia has only 1% of developing and continuing into endometrial cancer. Complex hyperplasia, 3% chance. Atypical simple, 8%, but complex atypical hyperplasia a whole 30%. Now, 25 to 40% of patients with atypical complex hyperplasia have a concomitant carcinoma. I don't want to bore you with these slides, but just to mention, these are, for those who are private to pathology, these are glands. These are basically endometrial glands. These are endometrial glands, which you can see over there. It's typical hyperplasia. There are no features of invasive disease. And this one is a typical endometrial hyperplasia that would generally be the picture of what you see. This is still endometrial gland, as you can see over there, but there's no invasive disease, but it has all those typical features of hyperplasia, which include enlarged nucleus, irregular size and shape, and all that. Now, as I said, endometrial cancer is not a single entity. There are several entities. So when you hear a patient has endometrial cancer, we should actually be curious to know what type of endometrial cancer is it. Because there are several types. They behave differently. Some are very aggressive, others are high risk, others are low risk, others are indolent, they're not as aggressive, others have very good outcome, and others have very poor outcome. So there are two different subtypes, which are recognized on histological appearance and behavior. So type 1, which we said is generally estrogen dependent, we have the endometrioid type. The most common account for 80%. The main risk factor here is hyperestrogenism, and these tend to be hormonally responsive. They have favorable prognosis with appropriate therapy, and they have an 83% all-stage 5-year survival. Type 2 is non-endometrioid type. It accounts for 15% of uterine carcinomas. It's non-estrogen related, as we have said before. These patients tend to be much older, non-white, multiparous, current smokers, non-obese. They're more biologically aggressive, they're high-risk tumors, they're unresponsive to hormonal therapy, they're classified as high-risk or high-grade. They have a 53% all-stage 5-year survival, and they represent around 50% of all relapses. This is just to illustrate what we are saying. So type 1 there, we have endometrioid, which is the commonest, but then we have other smaller entities, mucinous, squamous. Type 2, mostly we have serous papillary and also clear cell carcinoma. This is for those who may be interested in the histological types. This is well differentiated, the upper one. The middle one is moderately differentiated, and the lowermost is poorly differentiated. So the pathologist would usually report either of these appropriately. Staging. In oncology, usually we talk of and in gyne malignancies for that matter. They're usually classified according to FIGO, that is International Federation of Gynecologists and Obstetricians. And they're usually staged from stage 1 to stage 4. And as a principle, usually stage 1, it is confined to that particular organ. And stage 2, next to the organ, stage 4 is when you have distant metastasis. So that may not be as clear. Let me go to this other table. I don't want to go to a lot of details on this. You can always refer, it's there always online. So stage 1, just to have an idea of how these tumors are classified or staged. Stage 1 is when the tumor is contained and confined to the corpus uteri. And here we have stage 1A. and 1B. In 1A, there's no, or there's less than half of myometrial invasion. 1B is invasion equal to or more than half of the myometrium. Now, of interest here is stage 2, and this usually helps us to determine what type of surgery treatment to do. As you can see, stage 2 does not have A and B. It's only 1. And this is where you have tumor which invades the cervical stroma, but does not extend beyond the uterus. And this one generally we treat it as cervical cancer. This is where you do radical hysterectomy, pelvic lymph node dissection, and para-aortic lymph node dissection. And of course, you do a mentectomy and peritoneal washout. Stage 3 is A, B, and C. This is where you have local or regional spread of the tumor. Stage 4 there, the tumor invades the bladder or the bowel, just like we usually classify cervical cancer. Or B, 4B, that's when you have distant metastases, including inguinal nodes. Yeah. Now we're almost finishing, but this is just for those who are interested in histological appearances. This one here, as you can see, is a well-differentiated secretory carcinoma. You can see the glands there, very, very clear, quite artistic, so to speak. That is a well-differentiated secretory carcinoma. And then on the right there is generally what we call clear cell carcinoma of the endometrium. Pathologists will tell you they have particular cells which they call hobnail type of cells. But my cursor is not working very well. I think it keeps flying all over. But there are so many vacuoles areas. The white areas are usually that's where it gets its name. The clear cells. Cells have they look clear, as you can see over there. The lower one is the commonest. It's called this, not really a commonest, but it's high risk or high grade, so to speak, which is called serous type. So we're almost finishing so that we go to the discussion. Having said all this, not all endometrial cancers are primary. Some of them may be secondary, meaning they are metastatic from other organs, coming all the way to the endometrium. And the ovaries are the most likely genital sources of metastasis. The extragenital sources might be the breast, the stomach, the colon, the pancreas, the kidneys, although any disseminated tumor can actually involve the endometrium. And in this case, usually lymphatics are involved. When it comes to investigations, we do the baselines like complete blood count, the UECs, LFTs, an ultrasound scan. We basically do metastatic workup where you screen the whole body. You may use an ultrasound scan, abdominopelvic, and a chest X-ray at the very minimum. But if you do have an MRI, then you can do an abdominopelvic MRI or a CT scan of the abdomen and pelvis. Most of these patients are old, so an ECG and an echo would be appropriate. Cystoscopy and colonoscopy will help in the staging to see whether the bladder or the colon is involved, depending also on the presentation. A barium meal may be indicated. Now, CA125 may be, usually we use it for CA ovary, but it may be increased in CA endometrium, especially when we have extrauterine disease, and it tends to prognosticate. It's a poor indicator for survival when CA125 is elevated for CA endometrium. So it's basically work in theater. Briefly on the treatment, I've already alluded to that. Surgery, where we do, so it is not just a matter of doing simple TH and you're done with CA endometrium. and that is it. It has to be staged, and most often staging is surgical. So that is why you'll have an indication from the images, but during surgery is when you actually do the actual staging, and then of course the pathologist report will tell us the extent of the disease. So you do peritoneal washings, you explore the abdomen, the whole abdomen, the pelvis, you take biopsy from any suspicious areas. You do the TH-BSO, you do a omentectomy, and depending on the extent of the disease, you may do lymph node sampling. Or if it is involving the cervix, then you do radical hysterectomy, which of course involves lymph node dissection. Now, indications for pelvic and paraortic lymphadenectomy, just for interest sake. Usually here we look at endometrioid grade, and when we have high-risk types like clear cell, serous, and squamous, and when we have lymphovascular space invasion, or we have myometrial invasion more than half, or the cervix is involved, or the tumor is more than 2 centimeters, or when you have a disease which is extrauterine, then you do lymph node dissection. Of course, complications which go with lymph node dissection, like wound infection, embolic phenomena, where you may have a pulmonary embolism, excess blood loss, gastrointestinal injury or obstruction, or lymphocyst formation. Lymphocyst formation is when you have accumulation of lymph within the pelvic or abdominal cavity. Now, as you finish, the other treatment modalities include chemotherapy. Generally, we may use paclitaxel, cisplatin, or carboplatin, or doxorubicin. But of importance is to know that after surgery has been done, there has to be clear, it has to be clear whether the patient requires adjuvant treatment, meaning additional treatment, or not, so that this patient is referred appropriately. Other than saying, you've done TH-BSO, and therefore reassure the patient that nothing else is required. In some situations, we may have palliative progesterone. Depending on the stage, there's a place for external beam radiotherapy or internal radiation or intracavitary radiation. So when you look at the prognosis, there are many factors which determine prognosis. A younger patient usually has a better outcome. The histologic types, we have said, the endometrioid types are better than the serous and clear cell. Histologic grade, well differentiated, are usually better. When you have less myometrial invasion, it is better. When you don't have lymphovascular space invasion, it's better. When the cervix is not involved or the adnexa is not involved, then that is usually better. If you do peritoneal wash and the cells are negative, that is better prognosis. When you do lymph node dissection and the lymph nodes are negative for tumor, that is better prognosis. And of course, the smaller the tumor, the better the outcome. And those are really the things that we look at. And in cancer generally, and gynecological cancers in particular, follow-up is usually for 5 years, every 3 to 6 months, especially the first 2 years. And then after that, they're also seen appropriately 6 to 12 months. And every time they come, they should be, we usually look at, listen to them, take a history, examine the nodes, examine the abdomen and the pelvis, do pelvirectomy examination, and then investigate appropriately as per the presentation. I think this is my last slide. So prognosis, 5-year survival of endometrial cancer. These are Western figures. I hope as time goes by, we should be having local figures. So stage 1 is up to 87%, which is good, especially if it's well treated. Stage 2 up to 76%. Stage 3 drastically to around 60%, and stage 4, as you can see over there, only 18%. So overall is around 75% 5-year survival. And as we said, this is one of those tumors which you treat it initially very well. The outcome is very, very good. But if it's not appropriately initially treated and it recurs, you've probably lost the battle. Confucius is usually quoted as saying it does not matter how slowly you go, as long as you do not stop. So I encourage all of us, even as we have this webinar, we are all learning, and learning never stops. Thank you very much. I'll invite comments and questions. Over to you, Dr. Mukomba.
Thank you, Dr. Maranga, for that extensive and good discussion or lecture on cancer of the endometrial lining. I think the take-home message is any bleeding that is not the normal bleeding or bleeding in postmenopausal women should be evaluated thoroughly so that we don't treat for other things than treat on this cancer, which can be lethal if it's diagnosed in advanced stages. So a proper evaluation, and normally one doesn't need very complex tools. There's the usual things for physical examination, things like just a simple DNC, using an office pipette or doing hysteroscopy in the hospitals with the laparoscopy machine can give us a quick diagnosis in this condition so that we have appropriate management very early on so that we give our patients a chance to live. We now go to the question and answer session. Anybody with a comment to make can raise their hand, then we'll give them the opportunity. We start with the Q&A. Dr. Maranga, somebody is asking how smoking confers protection from endometrial CA. And we need to tell the person we do not encourage anybody to smoke because of protection from CA endometrium. The risks are more than the advantages.
Yeah, you are right, Dr. Mukomba, on that particular aspect. Of course, you're not going to encourage one to do smoking just to prevent endometrial cancer. And of course, not to the men, because we don't have endometrium in the first place. On a light note though, how does smoking confer protection? It's because of more like it causes endometrial hypoplasia, more of endometrial atrophy, so to speak, so that it does more or less prevent those the types of hyperplasia we talked about. There's obviously more to that, but that's what I would tell you for now. That is how it is thought to cause to protect. Having said that, of course, it is a whole risk of all types of cancers, lung cancers, even ovarian cancers, and the like. Yeah, and even cervical cancer. The other question there is, does uterine cancer? Yeah, go on.
Oh, sorry. Yeah, somebody is asking about peritoneal washout. What that is?
Yeah, the peritoneal washout is really part of gauging to know the extent of the disease. So peritoneal washout is you've opened up the patient, you're visualizing the abdomen. If there's ascites, you just draw around 20 cc's, you send it for cytology. Most often, unless the tumor has spread, you may not find any significant fluid accumulation in the pelvis or in the abdomen. So in that case, you take warm saline and you sprinkle it around the pelvis, and you collect it at the pouch of Douglas, 20 cc's or thereabout, and then you take it for cytology. So the pathologist or the cytologist will tell us if that tumor had come out from the endometrium to the extrauterine space, if the cytology is positive. If it's negative, then it's a better prognosis.
Okay, thank you. Somebody was asking whether uterine cancer affects younger women. Hello. Yeah, whether uterine cancer affects younger women.
Oh yeah, yeah, that's a good question. Does it affect younger women? Yes, it does. So as much as we are talking about postmenopausal women, it's because it's preponderant there. It is more, it's more prevalent in those who are postmenopausal. It's last year or the other year, I think the other year, a lady, a 38-year-old who had presented to us with the abnormal uterine bleeding, had even been put on Mirena. She was not improving. And then we just thought we could do endometrial sampling, and it came out as endometrioid cancer of the uterus. And then, of course, she had to undergo, luckily it was very, very early, stage 1A, grade 1. So she did not have to undergo further treatment apart from the initial extensive surgery. So yes, if you have a lady who is presenting to you with abnormal uterine bleeding, you've tried, of course, it's not number one on the top list. It's probably just hormone imbalance. But if you have tried everything and nothing is happening, just take some endometrial sample just to be sure that you're not missing out an early endometrial cancer. Now, the other bits, yeah, go on.
Dr. Nigo is asking whether you do pelvic MRI or CT scan and which is better at staging.
Yeah,
MRI.
Yeah. So as we said, we have to do metastatic workup, which means we scan the abdomen, the pelvis, and the chest. So if you are at Mashinani where you don't have much of the MRI or the CT, but at least you have an X-ray, then do a chest X-ray. And you have an ultrasound scan, do an abdominopelvic ultrasound scan. So those two would generally point you towards the diagnosis and the extent of the disease. If you have a CT scan available, then do a CT abdominopelvic. And if you feel there may be mets to the chest, then a CT chest would be okay. If you have all of them at your disposal, MRI would be superior. Abdominopelvic MRI would be best because it has better resolution for the soft tissues of the pelvis. So it will give you better staging, radiological staging, so to speak, at least to give you a guide in terms of what might be the extent of the disease before you do the treatment.
Yeah, I think the other one question is comment on a patient who has had hysterectomy due to abnormal bleeding, then the histology comes back as endometrial cancer.
Yeah, that is, it's not uncommon, actually. There are times when you may do, a patient may have fibroids, or the tumor may be misdiagnosed on scan, ultrasound or otherwise, as fibroids. You do a hysterectomy and you find out it is reported as endometrial cancer. Now, in this situation, that means that we actually haven't done adequate surgery or staging surgery for this particular patient. So the treatment thereof will be individualized. Like what was actually the extent of this cancer in this particular specimen? Is it stage 1A or 1B, or are there indications that the tumor may have gone beyond the uterus? Now, it depends. Sometimes there may be, and if operable, one may still go in and do a proper staging surgery where you do infracolicommentectomy, you may do lymph node sampling as appropriate. Or sometimes you may just go to the other adjuvant treatment, cognizant of the fact that this patient hasn't had adequate surgery. So you may give, depending also on the histological type, you may have the option of giving chemotherapy, usually 6 cycles of paclitaxel cisplatin most of the time. And you may go all the way to give external beam radiation and brachytherapy, which is internal and external radiation. So this should be individualized, and preferably it should be referred to a gynecologist if available within your locality.
I think maybe a last one, since time is not on our side. Somebody is asking about the risk of somebody with endometriosis and endometrial cancer. Yeah. And also you can spend time and the relation between family planning methods and endometrial cancer.
Yeah, so we did say that combined oral contraceptive pills, they are protective. Now, endometriosis, does endometriosis put you at risk of endometrial cancer? Now, endometriosis has been known to be more of a risk for ovarian cancer rather than endometrial cancer. But that's what I'll refer to the panelists also to give their opinion on the same. But really, on this particular one, not a strong risk factor really as yet identified.
Okay. So I think
Well,
one last
was,
one.
Go on.
Go on, Dr.
I think this something else which comes up is how do you treat endometriosis? It seems there's more interest in endometriosis than endometrial cancer, which is okay. Still falls under our area. Treatment of endometriosis is, there are many ways of treating it. There is no single way of treating it. It depends on the goal of treatment. Does this particular patient desire fertility at that particular time, or she does not? If she doesn't, then you have option of giving treatment like Vicen or GnRH agonist like Zoladex and the like. But if she is keen on fertility, then you treat the symptoms and you may give ovulation induction medication for them to conceive. So treatment depends on what are the goals of treatment per se. Sometimes surgery may be indicated, but not always, usually mainly for diagnosis rather than actual treatment, unless we are talking about additions. How do you prevent cancer from endometriosis? I'm not very sure on how do you prevent that. Maybe Dr. Mukomba can comment on that particular bit. Unless, of course, you if the patient has finished childbearing, and then there's an indication for a different indication really for THBSO, then that may apply. But obviously you're not going to give THBSO just because a patient has endometriosis. You have to individualize the treatment. Thank you.
Okay, yeah, I think we have tackled most of the questions. It's already 3 or 5. The other questions are really on what we have covered. I think we can, thank you very much, Dr. Maranga. Thank you everybody for
Thank you.
attending. Until we can now conclude the webinar and back to the research team. Next time it will be on cancer of the ovary.
Thank you, Dr. Mukomba, and all those that have attended. Santeni.